Good afternoon, everyone. Welcome to Pediatric Grand Rounds. Dr. Hirsch sends his regrets he could not be here with us today. So it's my honor to welcome you all to Pediatric Grand Rounds and to introduce our speaker for today, Dr. Rachel Zafnes. Dr. Rachel Zafnes is a pediatric pain psychologist and assistant clinical professor at UCSF Children's Hospital Oakland, where she teaches pain education for pediatric residents. She's an expert on non-pharmacological approaches to pain medicine and is a 2021 Mayday Fellow. Dr. Zafnes serves on the boards of the American Association of Pain Psychology, where she founded the Pediatric Division, and the Society of Pediatric Pain Medicine. She's the author of the Chronic Pain and Illness Workbook for Teens, the first pain management workbook for youth, and writes the Psychology Today column, Pain Explained. She leads pain workshops for multidisciplinary healthcare providers and consults on the development of integrative pain programs around the world. Dr. Zafnes trained at Brown University, Columbia University, UCSD, the NYU Child Study Center, and St. Luke's Mount Sinai Hospital. Her second book, The Pain Management Workbook, was released this month by New Harbingen Press. And with that, please welcome Dr. Rachel Zafnes.
Thank you so much. I have to say, like, no matter how long I do this, I always feel really embarrassed when people read my bio. I do not know why. Okay, so I'm going to share my slides with everyone. So just give me a moment to get those up. Okay. Great. Good. Okay, so welcome to Grand Rounds. Thank you so much for having me. I love UCSF. I'm really committed to UCSF. I think it's an amazing institution doing amazing things. Again, I'm a pediatric pain psychologist. I also do adult pain psychology. I teach pain education at UCSF and also pain education at Dartmouth. I did a visiting professorship this year at Stanford also to teach pain education. So really, I'm just a big pain nerd. I hope you enjoyed today's talk. We're going to cover a lot of information. But hopefully it will keep you interested, even though it's Zoom and we're all so tired of online everything. Okay, so like any good presentation, we are going to start with a case example. This particular case example, JR, 16-year-old Caucasian male. I also want to interrupt myself to say, I am a native New Yorker. I talk really fast, so I hope someone will type into the chat and interrupt me if I go too fast. Okay, 16-year-old Caucasian male. When I met him, he had a slew of medical diagnoses, including chronic migraine, abdominal migraine, and cyclical vomiting syndrome, among other things. He had been homebound, pretty much in bed and on his couch for about 4 years. He had seen more than 14 physicians and specialists, and he had been on over 40 medications for his pain, including opioids and Thorazine. If anyone doesn't know what Thorazine is, it's a doozy for a child to be on for pain. He was understandably too fatigued and sick to study or socialize. He was not going to school. He was not seeing friends. He was not getting very much exercise. And he was so behind in school that he was at a 7th grade education level, which he was really, really self-conscious about. So we're going to get back to our friend JR in just a moment. I want to talk now about what I call the pain problem. The pain problem is immense. The majority of healthcare providers are not trained in pain, and that is true across disciplines. That is true in medicine, that is true in nursing, that is true in psychology and social work and child life. It's absolutely astonishing, the dearth of pain education across healthcare disciplines. In fact, and I hope you're sitting down, and I hope you are eating a nice meal before I give you this fact, 96% of medical schools in the United States and Canada have 0 dedicated compulsory pain education. 96% of med schools in our country are not disseminating accurate or effective pain education. Ironically, pain is the #1 reason for doctor's visits. The problem is that even among people who are trained, much is missed. There is a focus on the body and on pills and procedures as treatment when it comes to pain. And what is missed when it comes to pain education most of the time is the role of beliefs and perceptions and emotions and context when it comes to pain. And by that, I mean, what we miss in many pain education programs, those that exist, is the role of the brain. So I'm gonna say this to you the way I say it to the patients who come into my office. Ready? It is very easy to believe that pain lives exclusively in the body, right? If your back hurts, it's very easy to believe that that pain lives exclusively in your back, of course, and that to treat it, you need to target exclusively your back. However, science tells us that is not accurate. That is not actually true. One of the reasons we know this is because of a condition known as phantom limb pain. And phantom limb pain is when an accident survivor or a trauma victim loses a limb. They literally lose an arm or a leg, but they continue to have terrible pain in the missing body part. If pain lived exclusively in the body, no limb should mean no pain. And the fact that you can continue to have leg pain when you don't have a leg tells us that pain is actually constructed somewhere else. And that somewhere else is the brain. So let's talk about that for a minute. I am a big fan of clinical examples. They really help me understand really complex things like pain. So we are going to take a look at two different clinical stories. I call these a tale of two nails because it rhymes. And who doesn't like rhyming on a Thursday morning? Everybody does. Okay. Tale number one is from the British Medical Journal in 1995. They reported that a 29-year-old construction worker jumped off a plank straight onto a 7-inch nail, and it went right through his boot. And that's an actual picture of the gentleman's foot. And he was in terrible, terrible pain. And so his colleagues rushed him to the emergency room. He was sedated with intravenous opioids, and the good doctors removed his boot and discovered, much to their shock and surprise, that a miracle had occurred. The nail had passed between the space between his toes. There was no puncture wound. There was no tissue damage. There was no blood, but the pain was real. What had happened? How is that even possible? His brain, otherwise known as your danger detector, because by the way, pain is your body's warning system. His brain used all available information to decide whether or not to make pain and how much. That's what your brain is always doing. So his brain used context, information about his dangerous work environment, where a lot of people get hurt. It used memories of past pain experiences, including ones he had had on the job site. His brain used all 5 of his senses, including the visual of this nail sticking through his boot. And of course, it used thoughts and it used emotions, including panic. And because his brain perceived potential threat of danger, it made pain to protect him, because that's pain's job. Pain's job is to save your life. Tale number 2. This is from the Journal of Psychosomatic Medicine in 2007. Like many of you, I am a real science nerd. I am always in search of great scientific papers. This is one of my all-time favorite papers, Dimsdale and Dancer, 2007, Journal of Psychosomatic Medicine. If you want to get nerdy this weekend, pull it up. They reported that another construction worker, because that is apparently the most dangerous job a person can have, was on a job site when a nail gun misfired and it ricocheted backwards and clocked him in the head. But he saw the nail shoot across the room and bury in the wall across from him. But the nail gun ricocheted backward, clocked him in the jaw. He had a mild toothache and a headache, but he continued on with work and life for 6 days. And at the end of 6 days, he turned to his wife and said, I think I'm gonna get my toothache checked out. He went to his dentist, who did a scan of his head. And to both men's surprise, they discovered a 4-inch nail embedded in his face. And as you can see, this is an actual MRI of the gentleman's head. You can see the nail, and it's protruding into his cerebral cortex. I think it's a CAT scan, actually. It's protruding into his cerebral cortex, about 1/4 of an inch. So real danger, real damage, very little pain. How is that possible? His brain, again, had a false perception of safety. He saw that nail travel across the room and bury in the wall. So despite the fact that his brain, or his danger detection system, used all available information, used contextual and emotional and physical clues, it still failed to trip the pain alarm. Because like every system in the body, the pain system can fail. And that's very important for us as doctors and healthcare providers to remember that, like all systems, the pain system can fail. It's not infallible. So what are the conclusions we can draw from pain science to inform our practice? This is actually really critical for all of us. Thing number one, this thing we call pain is both physical and emotional 100% of the time. Both are critical for the production of this thing we call pain. Thing two, pain requires sensory input from both brain and body, plus contextual input from the environment. All of these things are required to produce pain. Body sensations, brain interpretations, and contextual input all work together to create this thing we call pain. And thing three, pain is not an accurate indicator of tissue damage. The amount of pain that you have, the amount of pain that your patient has, is not proportional to the degree of injury they have. For example, you can have pain in the absence of damage, like a nail to the boot, but not the foot. And you can have no pain or very little pain in the presence of damage, like a 4-inch nail to the face. All right. Our current model of pain medicine is biomedical. And what that means is when we see a kid with pain, we throw pills and procedures at it. However, it isn't working. The prevalence of chronic pain is actually on the rise. And as we all know, we're in the midst of an opioid epidemic, and we need alternatives. The opioid epidemic, just to say, water break, please. The opioid epidemic during COVID is exploding. We need alternatives. So science tells us that pain is not purely biomedical. Not ever. Rather, pain is what we call biopsychosocial. Bad time. This is what happens when I get excited. I lose my voice and then I can't talk. Okay, science tells us that pain is not purely biomedical. It is what we call biopsychosocial. And that means that the most effective treatment for pain is necessarily biopsychosocial. And this means there's 3 equally important domains for us to target if we actually want our patients to get well. So let's look at that for a moment. Hopefully my choking got everyone's attention, at least that. Okay, so here's what we call the biopsychosocial model of pain. And pain lives here in the messy middle. And what I really want to say to everybody is everything lives here. Every health condition, everything. Cancer lives here, and depression lives here, and obesity lives here, and PTSD lives here in the middle of these 3 things. So let's take a look at this for just a minute. The bio or biological domain of pain is the one at the top, the bubble at the top, and it's the one that we probably know the most about. And by us, I mean physicians and doctors. The biological domain of pain includes genetics, tissue damage, system dysfunction, inflammation, diet and exercise, and sleep. Critically important when it comes to pain and its treatment. However, what I want you to notice is that 2/3 of pain is not bio. So when we focus on purely biomedical solutions for pain, we are actually missing 2/3 of the pain problem. We cannot do that anymore. So let's look at the other 2 bubbles, the other 2 domains of pain. The psychological domain of pain, unfortunately, comes with an abundance of stigma, and we're going to talk a little bit about how to target that. The psychological domain of pain incorporates thoughts and beliefs, like the 2 nail stories, and research shows abundantly that thoughts and beliefs impact the pain we feel. It also includes memories, again, of past pain experiences. Research shows that these are stored in the hippocampus as far back as the first time you were held down and given an injection, by the way. Your emotions impact the pain you feel, absolutely, as do your coping behaviors, how you manage or navigate or deal with your pain. That affects the pain you feel. And most of our patients are in avoidance mode, and we're going to talk about what that means also. And then we have the 3rd domain of pain, which is the social or the sociological domain of pain. And by the way, that is everything else. It is socioeconomic status and access to care. It is race and ethnicity, family and friends, social media, and context and environment, literally everything else. And as we saw with the nail stories, of course, context and environment matter. Everything matters when it comes to the experience of pain, because pain is an experience, a biopsychosocial experience. Okay, so as we have said, we have an opioid epidemic. Throwing pills and procedures at pain exclusively does not work. We know it doesn't work. So let's talk about some alternatives. There are a host of biobehavioral strategies for pain medicine that have been shown to be effective for treating pediatric pain. One of those is cognitive behavioral therapy, or CBT. Everyone always thinks I'm saying CBD, but that is something totally different. I am talking about CBT, not CBD. Okay, what is CBT? It is an evidence-based treatment, not only for pain, but also for anxiety and depression and sleep and family dysfunction and trauma. And it surprises nobody in these grand rounds that all of those things are connected when it comes to pediatric pain. All of the things are connected. CBT ably bridges the gap between medicine and psychology, which is why I like it so much. I always want to live in that messy middle. It is skills-based and it involves home practice. A lot happens in the space between weekly sessions. And by the way, I try very hard never to call it homework because of course no child would ever talk to me ever again. CBT emphasizes a return to play, a return to school, and a return to functioning. And it teaches us that our thoughts and our feelings, both emotional and physical, and our behaviors are all interconnected. So I want to show you the CBT pain cycle so that you can take a look for yourself. Okay, I find pictures to be super helpful, especially when treating kids and families. It conveys information much simpler than I ever could. So here's what the CBT cycle looks like. It's unique for every patient who comes in your door. Everyone brings with them different thoughts, different emotions, different symptoms, different behaviors, but I just want to walk you through the general gist of this. So the CBT cycle says that the things we think, as you can see here, I'm broken, I'll never get better, affects our emotions or how we feel, anxious, stressed, sad, or angry, affects physical symptoms, how our bodies react to our thoughts and emotions, fight or flight, pain, symptom amplification, affect our behaviors or how we act as a result of how we're thinking and feeling, missing school, staying in bed, isolating. And what I want you to notice in the CBT cycle is that everything affects everything. There's no one particular order. All the things are connected all the time. So I want to give you an example of that, just so you can get a better sense. All right, back to our friend, JM. We are talking about his CBT cycle, and this is what it looks like. In this example, the CBT cycle begins with a thought. And in cognitive behavioral therapy, we pay special attention to automatic negative thoughts, and we call those cognitive distortions. Why? Because it is very easy to believe the thoughts that you have. Human beings have this terrible, terrible habit of believing the things that happen between their ears. I have a neighbor who has a bumper sticker and it says, "Don't believe everything you think," which I think is very, very wise, and we should all take that advice. So JM's cognitive distortion was, I'm broken, I'll never get better. I'm broken, I'll never get better. Now, you are a 16-year-old, you're supposed to be thinking about, I don't know, your prom and who's snapping you on Snapchat or whatever you think about when you're a 16-year-old dude. But instead he's thinking, I'm broken, I'll never get better. How does that make him feel? Well, naturally and normally, that makes him feel panicky and anxious and depressed. And what I want to say to you, everybody watching, is when you are treating people with chronic pain or dealing with people with chronic pain in your life, whether they be adults or children, you are going to notice that they may have a negative emotional response. When treating people with chronic pain, we often see anxiety and depression, and there's a lot of stigma associated with that. So I want to get rid of that right now, just single-handedly, as if I have that power. This is what we call a normal response to an abnormal situation. Of course, our kiddos are anxious and depressed. Their bodies are no longer under their control. Their life is now out of their control. They can't see their friends. They can't play sports. They can't engage in hobbies. They can't do the things they used to do because now they are chronically ill and chronically in pain. That is what we call a situational trigger. Much like the pandemic, COVID is making a lot of people anxious. Would you say that they're mentally ill? No, you would say that that is a situational trigger. And what we notice about these kiddos is that when we treat their symptoms and treat their pain and offer them some pain education, which is what we're doing today, their anxiety and depression often abate. I am not saying that people don't come in with pre-morbid anxiety and depression and other issues. Obviously, obviously they do. But it's very important to not stigmatize our patients and to recognize that there is a situational component to their emotional expression. Okay, so in the CBT cycle, the thoughts affect the emotions, affect the body. So what did JM notice? He noticed that when his emotions became intense and negative, when he got anxious and panicky and depressed and even angry, he would experience really intense pain flares. His migraines would spike, he would start vomiting, he would have panic symptoms. And I want to say this to you the way I say this to my kiddos. I'm going to advance a slide and I'm going to come back to this slide. So, emotions don't just live in your head. Emotions also come out in your body. Of course they do. Descartes is dead. There is no brain-body divide. That is not a thing. Your head is connected to your body 100% of the time. And science tells us that emotions are physical. So if you've ever had butterflies in your stomach, for example, before giving grand rounds, just for example, or if you've ever experienced your sympathetic nervous system response, you know that your emotions are also physical. They come out in your body. But by the way, the kids we work with don't know that. No one's ever told them that before. And just in case you need a little bit more evidence, if you've ever read the ACEs studies, the Advanced Childhood Experiences studies, they confirm that toxic stress and emotional trauma in childhood are associated with and sometimes lead to the development of illness and chronic pain. This has been known for many decades. There is always a relationship between emotions and physical sensations. But somatic, for some reason that I don't know, and maybe at the end of this, you guys can explain this to me, somatic has become a bad word in medicine, and I don't know why. Of course, emotions manifest somatically. So negative emotions can cause pain. They can cause vomiting. If you've ever had a tension headache, you know that negative emotions can cause pain. Negative emotions can trigger flare-ups. Negative emotions can exacerbate the symptoms of an underlying condition, and negative emotions can maintain pain. So I know that you signed up to be physicians and healthcare providers, but guess what? You are also educators, or at least you have the opportunity to be. You are the first line of defense when it comes to treating kids with pain. Kids see you first. I am the last stop on the train. So you get to explain to these kiddos that their emotions are physical, that their emotions are going to amplify the physical pain they feel. You also get to explain to them that a biopsychosocial issue like pain is going to require a biopsychosocial solution. And that is why you're going to be referring to them to all these other non-pharmacological biobehavioral solutions and treatments. All right, back to our friend JM. He's thinking negative thoughts. His emotions are negative. His body's freaking out. What does he do as a result? He does what every red-blooded American child does. He avoids school and activities. He doesn't get any exercise. He's not getting any sunlight. He's hanging out in bed all day. He's on his screens. He's playing video games. His sleep and diet are total crap. So now that he's doing that, what is he thinking? He's thinking, pain has taken everything away from me. And now how is he feeling? He's feeling hopeless and powerless. So what I'm trying to illustrate is that this cycle cycles around. The thoughts and the emotions and the behaviors and the body are all interconnected all the time. So I often get asked, what does psychology have to do with pain? Like, this is great, but I have a physical problem. Why are you sending me to a psychologist? So what I've found is that what parents are asking 9 times out of 10, and even what doctors are asking, like, why are you sending someone to a psychologist for a physical problem? What they're asking a lot of the time, especially the parents, is, are you saying my child is crazy? Are you saying it's all in her head? Are you suggesting she has a mental illness? And that's not what you're saying. But the stigma is a real barrier to treatment. So I want to give you a tip. And I found that this tip really explodes the stigma around referring to non-pharm providers or pain psychologists like me. And the tip is this. I want you to call people like me pain coaches from now on. And a psychologist or a social worker or a PT or an OT or a child life specialist, anyone who's a non-pharm provider can be a pain coach. And here's how I explain it, or here's how I teach it. If it is okay to go to a soccer coach to get better at soccer, It is surely okay to go to a pain coach to get better at dealing with pain, because pain is so difficult to deal with and you deserve support. And that works 100% of the time. And it removes some of the unfortunate stigma we have around this psychosocial approach to pain medicine, which is really a shame. Okay, the other thing that I do, water break part 3. The other thing that I do is I teach the real biological connection between emotions and pain. So I hope you are prepared for some really nerdy pain neuroscience. You're probably not drinking bourbon because it's the middle of the day and you're working, but maybe some tea or coffee to go along with your nerdy neuroscience lunch break. Okay, so back in 1965, these two wonderful doctors, Melzack and Wall, one the first ever pain psychologist, one a neuroscientist, came up with the gate control theory of pain, and they forever revolutionized pain medicine. And it has since evolved into the neuromatrix theory of pain, and it continues to evolve today. And here's essentially what it says. There is no one single pain center in your brain. No, that is not a thing. Rather, pain is what we call a diffuse neurological process. There are many parts of the brain that process pain. 3 in particular that I want to tell you about right now. And by the way, I explain this to every child who walks into my office and every parent. Why? Because I am a firm believer in this idea that every patient deserves to understand their pain and deserves to understand their body. And research shows that explaining pain to people can actually reduce the pain they feel, which is another lecture for another time. 3 parts of your brain in particular that I want to tell you about that produce your pain. One is your cerebral cortex. That is the part of your brain responsible for thoughts. There's a method to the madness here, obviously, right? Prefrontal cortex is the second part of your brain that I want to tell you about. That's the part of your brain responsible for attentional processes, or what you're focusing on. And the third part of your brain I want to tell you about that processes pain is your limbic system. What is your limbic system? Your limbic system is your brain's emotion center. Your brain's emotion center. 100% of the sensory signals from your body filter through the limbic system, your emotion center, before they become this thing we call pain. And that means, children and everybody, families, that pain is both physical and emotional 100% of the time. The question I get asked most is, do you treat physical pain or emotional pain? And now I just nod my head and I say yes. So again, this is how I present it to the kids in my office. I answer a million questions, but I think this is pretty easily digestible. Okay, so how does this work? I want to introduce you to a metaphor for explaining pain that again is child-friendly and very parent-friendly as well. And it will set you up for referring families to a biopsychosocial approach to pain medicine. So I want you to imagine for a moment, and again, I'm teaching this to you. I know you guys are all smart doctors. I'm teaching this to you the way I teach it to the families and the kids in my office in the hopes that you will steal it and use it. I want you to imagine that in your central nervous system, you have what we're going to call a pain dial. And it's much like the volume knob on your car stereo. And you can turn the volume up and you can turn the volume down. And there's lots of things that change pain volume, but 3 in particular that I want to tell you about. 1 is stress and anxiety. 2 is mood and emotions. And 3 is attention. Specifically, here's how this works. When stress and anxiety are high, for example, during a pandemic, and your body and your muscles are tense and tight, and your thoughts are worried, your brain sends a message to your pain dial, turning volume way up. So whatever pain you had before, when you're stressed or anxious, it now feels worse. 2 is mood. When mood is low, you're miserable and depressed, which often happens when we have pain. Your limbic system sends a message to your pain dial, turning volume really high. Whatever pain you had before, when your emotions are negative, angry, sad, miserable, pain volume is higher. 3 is attention. So when you're home in bed, you're missing school, you're not seeing friends, you're not engaged in hobbies or activities, your prefrontal cortex sends a message to your pain dial, amplifying pain volume. But the reason this is really important for us is because the opposite is also true. The opposite is also true. When stress and anxiety are low, our bodies are relaxed and our thoughts are calm, our brain turns down pain volume, making pain feel less bad. And 2 is mood. When emotions are positive, we're feeling good, we're engaged in pleasurable activities, we're happy. Limbic system turns down pain volume. And 3 is attention. When we are engaged in life and focused on other activities, if you've ever been so absorbed in something that you briefly forget about your pain, that is not magic. That is your brain's pain dial, regulating the pain that you feel. So when mood is high, emotions are positive, attention is focused on other things, you're distracted, and when stress and anxiety are low, that is a recipe for low pain. Why do I think this is a critical thing to teach to children and families? Why? Because pain takes away power. That's just what it does. When you're a child in pain, your life and your body have been taken away from you. They're no longer under your control. When you teach a kid and a family about their pain dial, what you're actually doing is giving them their power back. You are saying there are things you can do to change your pain by changing stress and anxiety and mood and cognitive processes and also coping behaviors that will actually completely change your experience of pain. It is such a great gift to give a child their power back. All right, so what is the content of CBT? We've sort of been talking about it for a while now, believe it or not. And this is sort of the crux of most biobehavioral approaches. There are 4 main components of cognitive behavioral therapy. The first is pain education, which is what we've been doing here today. A lot of psychoeducation, talking about the pain dial and how pain works in the brain, the relationship between thoughts and emotions and pain, this thing we call hurt versus harm. Just because something hurts does not necessarily mean it's harming your body, like the man with the pain who had a nail in his boot, but it actually wasn't in his foot. There was no tissue damage. We talk about the process of how pain becomes chronic, the process of central and peripheral sensitization. Believe it or not, there's language for that I've developed that you can use with kids. We talk a lot about affect education, the role of emotions in pain. And we spend a lot of time also on lifestyle factors. Again, back to the bio domain of pain. We talk about sleep hygiene. We talk about nutrition. We talk about exercise and how moving your body is actually going to really help your pain, which is so ironic and counterintuitive. The next thing we do in CBT is behavioral approaches. The way I think about behavioral approaches is, what have we been doing to manage your pain? Has it been working? Yes or no? And what can we do differently? So behavioral approaches include a wide variety of techniques. There's pacing for pain, which is much like pacing for a marathon. You don't tell someone to go run 26 miles tomorrow, they would die. Actually, most of you would probably be fine, but I would die. Instead, what you actually do is you gradually, exponentially increase exposure to small amounts of physical and cognitive activity. And for you have the patients identify their goals. So for some kids, it's reading a whole book, especially if they've had a TBI or post-concussion syndrome or terrible migraine. It's hard for them to focus. It can also be any physical activity. Some of my patients want to go back to soccer, for example, and we get them back by implementing a pacing plan. There's also relaxation and mindfulness strategies. There's an abundance of literature on mindfulness for pain. Believe it or not, I was not a believer until I went down this rabbit hole. MBSR is called mindfulness-based stress reduction. It's an entire protocol for pain management. It has a lot of evidence of effectiveness. There's also distraction strategies for pain to engage the prefrontal cortex. There is also something called biofeedback, which I have learned I have only learned recently that it's not ubiquitous in medicine. Biofeedback is an absolutely phenomenal tool for treating chronic pain in kids. It is a process by which children learn to have control over formerly unconscious biological processes like heart rate and skin temperature and galvanic skin response and muscle tension. It is so powerful. How do I say this? I have kids who I teach them to warm their hands to 90 degrees. And full disclosure, when I first learned biofeedback about 10 years ago, it was by a professor at the University of San Francisco. And he said, I want you to sit in this chair and I am going to teach you to warm your hands to 90 degrees in 2 sessions. And I said, I am a scientist and I do not believe in voodoo. And he said, okay, well, just sit in the chair. And he did all these techniques with me. He did relaxation and guided imagery And we used autogenic phrases, which is when you say things to yourself, like my hands are heavy and warm. And no joke, within 2 sessions, and by the way, even talking about it, my hands get red and hot because I've been practicing it so much. But within 2 sessions, I could warm my hands to 90 degrees, and I am normally someone with cold hands. And when I teach this to my patients, the kids with pain, inevitably they say, oh my God, I can make fireballs with my hands. What else can I do with my brain? And that is exactly what you want for kids living with pain and illness. You want them to believe they have some agency over their bodies. So there's a lot of strategies in here that I highly recommend. 3, cognitive techniques. We teach kids to decrease their distressing thoughts, their distortions, to increase coping statements, and to increase self-efficacy beliefs. And the 4th component of CBT, which is not to be ignored, is parent training. So full disclosure, don't tell anyone I'm saying this. I guess this is being recorded, so everyone will know. But in any given moment, I am usually treating parents without seeing the child, giving them tips and coaching, and the child is getting better. The child is not even in my office. In any given moment, I'm just working with the parents and the child is improving. There is an abundance of literature in the pediatric pain world showing that parent factors and family factors are critically important when it comes to pain, and that there are a lot of roundabout ways or backdoor ways we can help kids with pain by helping their parents. So we reduce anxiety contagion, because when parents are panicking, children are panicking, and of course that turns up the pain dial. We help with positive reinforcement and limits. Like, for example, you cannot stay in bed all day, every day playing video games. It's really bad for your pain. And we help parents learn to increase their child's independence and confidence. All right, back to our friend JR. What did we do with him? We did all the things. We did psychoeducation. We did some cognitive restructuring and challenging his distortions. We put together what's called a 5 things plan. A 5 things plan, quite literally, is what are 5 things you're going to do today to manage your pain effectively? And that might be across the biopsychosocial domain. So for example, you're going to go to bed at a reasonable hour, or whatever the time is, 10 p.m. You are going to eat your vegetables today. You are going to go for a 10-minute walk. You're going to get some sunlight. You're going to engage in some social activity, whatever the 5 things plan is. And you earn your screens for doing 5 things every day. We did some activity pacing and academic pacing. He learned some biofeedback tools. Relaxation and mindfulness were really, really helpful for him. He learned a whole host of coping tools. And the best part about JM was, as soon as he learned them, he was able to actually put them into action, and he was willing to do it. And of course, we did some parent training. So what happened? What happened was, within a few sessions, we noticed as he started doing some things, his anxiety started going down. His mood started going back up as he re-engaged in life. He increased social engagement, reached out to a few friends. He started walking around the block and then jogging around the block, shockingly. He walked to the dog park and made friends with other dogs and other dog walkers. And as he re-engaged in his life, and as he engaged in distraction strategies and all these other pain management strategies, what happened was that his pain started going down. And he got a tutor, and he was able to return to school, and he was able to return to soccer. And I went to his high school graduation a couple of years ago, which is a true story. And he got on stage and he said, if you had told me 4 years ago I'd be graduating high school, I would not have believed you. And we all cried. And he knows how to manage his pain now. He still has occasional pain flares, because none of us are pretending that we're magicians. Sometimes he has pain. He knows exactly what to do. His pain is much better than it ever was. And turns out that he went off to college and was voted like captain of his swim team. So what I want to submit to you is that these strategies work for pain management. This is a kid who had previously been in bed for 4 years. And my pitch to you is that no child ever need have only one domain of health treated while the other 2 are ignored. It doesn't work. It doesn't work. All right. I am all about affordability and accessibility. And if you want me to get really angry, we can talk about the fact that CBT is not covered by most insurance companies. And also, there are very few pain psychologists trained in cognitive behavioral therapy. I think that all healthcare and all of these strategies should be affordable for all families. It should absolutely be accessible and affordable. So I put everything I do in my practice into a workbook. It's on Amazon. It's like 17 bucks. Healthcare should be affordable for all. Also, I feel very strongly that all providers should have access to high quality, non-pharm resources, including CBT for pain. So this is for families and kids, super digestible and approachable. And it's also for any healthcare provider who wants to be able to explain pain and wants to be able to offer more tools to patients. Affordability and accessibility is so critical for our patients, especially in the Bay Area with the population we see. Okay, I'm gonna get off my soapbox now. All right, so I'm a super hyper collaborative clinician. I do all of my work in the context of collaborating with physicians and PTs and OTs and social workers. So please reach out if you want to talk or consult anytime. My email is up here. Also, I have a really nerdy website. It's zafnis.com, just my last name. And I have a resources page. So if you want resources, books and websites and apps and journal articles that talk about chronic pain management, there's an abundance of stuff on there. Like I've been collecting stuff now for, I don't even know, like 8 years. So there's a ton of resources up there. It's zafnis.com and there's a resources page. I also lead pain workshops. If this is something particularly interesting or useful to you, please reach out to me. I'm running them, I think sometime this winter, not sure yet when. I also joined social media during COVID because I found that that's sort of the best way to meet some of my like-minded colleagues and to spread the word about a biopsychosocial approach to pain medicine. So if you would like to be friends on Twitter, you can tweet at me. I'm at Dr. Zafnis, or you can friend me. I don't even know what it's called. I'm not a social media guru. That is all. Thank you so much for listening today.
Thank you so much, Dr. Zafnis, for this very passionate and articulate plea, I would say, as well as giving us a good oversight of the work that you're doing. This is now open to discussion, and if you have questions for Dr. Zafnis, please type them in the Q&A. I have one already, that is, can we share your email address with parents?
My email address with parents, probably best not to. I actually have a full caseload right now. So I would vote no on that. I would vote no on that. I have a full caseload at the moment. Sorry.
No,
you can hold on to it for your use though. Maybe I won't be full in a couple of months.
Fair enough. I was also wondering, so my clinical work, and I'm sure that's true for some of the people in the attendance, in the audience as well, is very much based on in the inpatient setting. I work in the pediatric intensive care unit, and I oftentimes wonder, like, we can't necessarily steer away from the use of opioids and things like that, but I often wonder that we don't do enough to use alternative mechanisms for pain control, and also having an awareness of the long-term consequences of what we do to our patients in the ICU in terms of chronic pain complaints. Do you have any data on that and any suggestions on what inpatient practitioners can do to mitigate long-term impact?
You actually just asked a critically important question that I should have addressed earlier in the talk, and I think I need to work on that. Acute pain management, in my mind, is actually quite different than chronic pain management. For acute pain management, you absolutely should be using all the medications, 100%. For acute pain management, it's a different animal. I actually think maybe we should do a talk on the difference between acute pain and chronic pain, because we could talk about that for an hour. But with chronic pain, what we know is that the pain system is not working appropriately. With chronic pain, it's like this false alarm system that's beeping constantly and telling you that your body is in danger when it might not actually be. And with acute pain, that's usually not the case. So opioids for acute pain is actually totally appropriate. However, there are also non-pharm strategies and biobehavioral strategies we can use on an acute basis. Like a lot of people know distraction techniques, right? Like if you're giving a child an injection or something painful, distract them with screens. Like there's a ton of things you can do, right? For acute pain. Were you going to say something?
No, you're answering that part of the question. I guess my other part of the question is there any data about acute pain in the inpatient setting and then the impact on long-term pain?
I don't understand the question. I'm sorry. What do you mean? Is there data on how, I don't.
Do you see patients in your clinic with chronic pain for whom this all started with acute pain that was treated in an inpatient setting with opioids?
Oh. Yeah, I don't know the data on that, but yes, a lot of chronic pain patients start with an acute pain episode that was either not handled well or, yeah, absolutely. A lot of chronic pain episodes start with an acute pain episode, yes.
And then from the audience, I have a couple more questions. One, would you describe your experience with children who have sickle cell anemia and severe juvenile arthritis?
Yeah, can the person talk and say more about that question?
I don't know if we have that opportunity, especially since it was an anonymous attendee.
Oh, I don't know what to say about that. What about my experience is that these approaches are critically important for pain management across diagnoses. So yeah, in hem-onc and in sickle cell, yes. So the thing that's unique in my mind about sickle cell is that there are both acute pain episodes and like an overarching chronic pain presentation. So sort of the way we would tackle an acute pain episode versus the general chronic pain condition are sort of two different animals. But usually I put together a pain plan for acute pain flares. So the kids will write on like a 3x5 card their pain management plan for an acute flare, but then we'll have like ongoing management strategies from a biopsychosocial perspective for like, general chronic pain management. I don't know if I'm answering the question because I'm not exactly sure what the question is.
We'll move to another question. Actually, it says, sorry, I wasn't clear enough, but you were answering my question. I think this is the same attendee.
Okay.
Another question is about whether there has been any research on pediatric patients treated with opioids and other pain medications and how they correlate with later recreational drug use.
Oh, that's so interesting. I don't know the data on whether early opioid for pain turns into recreational drug use. I have seen it. Steve Long, who's one of my favorite people at UCSF, he presents on this in the class that I teach at Children's Hospital Oakland. And I remember vaguely that there was some data on that, but I honestly don't remember. I'm sorry.
How does diversity or healthcare adversity inequity affect your practice? Since you mentioned insurance coverage is inadequate in your area of practice.
Totally. Again, that's why I get on my soapbox. I feel really angry about it. So in my private practice, I have a sliding scale. So I like go down to $40 for the families that can't afford CBT. And there's a lot of them, but inevitably it's like, racial and ethnic disparities. So CBT is often not affordable for a lot of our families, especially in Oakland. I'm in the East Bay in particular. So yeah, I think we need to create more affordable and accessible resources. But inevitably what I see is in populations with lower socioeconomic status, they cannot afford this wide breadth of healthcare options that we say is absolutely critical for chronic pain management. So they're sort of stuck with whatever medications they've been given, and they don't really have the option to do many other things, which is why I think my understanding is UCSF is sort of moving into a more integrative model of health with pain and health in general, and sort of offering more of this stuff in-house. So for example, Amy Gelfand's Headache Center, which is absolutely amazing, now has 2 in-house pediatric pain psychologists. So anyone who gets in the door now has the option to access things like cognitive behavioral therapy for pain. But yeah, there are amazing racial and health and racial and ethnic disparities when it comes to pain management and health management in the East Bay for sure.
I think that that's the end of the list of questions that I have here. So I'm gonna end this then by thanking you again. Oh, wait, there's one more.
Yeah, if folks have questions, if folks have questions, I can stay here for another 10 minutes. So please ask me anything you want.
There's one more here. Are most of your consults via telehealth?
Are most of my consults via telehealth? With patients, do you mean? I'm assuming you mean with patients and not with colleagues. So I was doing about 10 months of pain psychology via telehealth. My patients hated it and I hated it. So now I am seeing my patients in person and outdoors. I think it's a critical, I think it's critical treatment. So I think it's like an essential service. So I don't feel bad about it. And the parents and kids want it also. So what I have found, this is just me personally, I know other people have strong feelings about this. I think virtual telehealth for kids with pain, especially from the psychological domain, is terrible. and much less effective. I know that as a clinician, I lose so much information when all I can see is like a head and shoulders. Like I just lose so much critical information. I lose a lot of information when I can't see the family together. So what I'm doing now is I'm seeing them outdoors at a distance and masked, and it's like absolutely changing my practice. And I'm finding it to be much more helpful. So I am seeing patients in real life. I hope I'm not being judged for that, but maybe you're judging me for that. I don't know.
All right. Well, thank you very much. This was really a delightful conversation. Oh, and another great question is popping up. Every time that there's nothing for a while, then there's something. Here we go. What is the timeline of receiving CBT therapy for children with chronic pain?
What is the timeline for receiving cognitive?
Yeah, so how long does a therapy typically last?
Oh, how long does it last? Okay, great. That's another great question. So if you look at the literature on cognitive behavioral therapy, it's an absolute mess. There's no operational definition of cognitive behavioral therapy. Like the definition I gave you, that's my definition of CBT. That's like exists in some studies, but not others. So different people have different definitions of what is included in cognitive behavioral therapy. That's thing one. Thing two is different people believe it should last for different amounts of time. So in some studies, people are delivering like 6 to 8 weeks. And in some studies, they're doing 12 weeks. And in some studies, they're doing multiple months of CBT. So in general, there's like a course of CBT that's about 12 weeks long. That's like what people normally, that's like a standard dose of CBT. I will humbly submit that with chronic pain work, more than 12 weeks is required and should be standard. More than 12 weeks should be standard in my opinion. And I often see kids for up to, I don't know, 6 months. However, I try very hard to not have like a standard stock answer for that, because I have also seen kids and families for just 6 weeks and their pain breaks and the cycle is broken and then they're gone and then they're done, they're back to life, right? So there's a wide range. And with the patient I presented, JR, for him, we saw major changes within the first 2 months. Like within the first 2 months, he went and got a haircut and bought a pair of new shoes and started walking. And all of us were like, something is changing, something is happening. And we saw a decrease in pain and symptoms, not far after that. So it's really individualized. It's like that most annoying answer you get in pain medicine, which is like, it depends, right? So it just depends on the kid, it depends on the family. But in general, the standard dose of CBT is 12 weeks for standard CBT. For chronic pain, I would say it's longer than that. And there's just a lot of individual variance.
Great, thank you.
Any more questions or thoughts? I know I presented a lot of controversial material, or maybe not. No?
I'm going to give it a moment, because every time that I think we're out of questions, someone pops up, but
okay.
It looks like we've had all the questions. So again, thank you very much, Dr. Zofnes, for this compelling and passionate talk, and to everyone who was able to attend, have a very good rest of your day.
Thank you for having me. It's really fun to be here. Hi.